cardiac's first surgeon who did successful open heart surgery. And it was a very complicated machine. It was built by the IBM engineers because he was a friend of John Watson, the head of IBM. But very few people know that it was not such a easy going. The patient number one, which John Gibbon operated, was a wrong diagnosis. They went from the right chest, they went to cardiopulmonary bypass, and the patient did not have an atrial septal defect. He had a patent ductus. And for cardiac surgeons among you, I don't have to explain it. It's an absolute disaster. The blood flows from everywhere, and that is impossible to control it from the right chest. Patient died. Patient number two was a young lady. He had really had an ASD, and he closed the ASD, but his pump oxygenator didn't function. First, it was too cleverly done by the engineers, so there were a lot of feedback mechanisms. The pumps kept stopping. So luckily a resident was sitting and he knew how to run it by hand. And the second thing is that his oxygenator stopped working. So instead of a thin film, there was a broad stream of blood across, and the blood was pumped back into patient totally black. So they were worried about the brain damage, but the patient survived. Patient number 3, number 4, and number 5 died, all of them. And it was such a disappointment for John Gibbon that he, father of cardiac surgery, stopped cardiac surgery, never did a cardiac operation again, and he became a professor of surgery, but he didn't do cardiac surgery anymore. And the level of the monitorization at that time and the equipment was really ridiculous. When you look at today, we only had a single ray cathode oscilloscope, which you could have either ECG or blood pressure, but not both simultaneously. And the Engstrom respirator, which was necessary then, took a good part of the operating room. And atrial septal defects, we used to close in hypothermia. The patient would be cooled in anesthesia to 30 degrees. We would open the right chest, close the vena cava, and then the heart would empty within a couple of beats, and the heart was empty. Open the right atrium, quickly suture atrial septal defect, and close the right atrium. You had 3 minutes. And the anesthetist was instructed to say half a minute, 1 minute, minute and a half, 2 minutes, and it was not easy to do this surgery. I am glad we stopped doing it. To repair the bigger problems in complex congenital anomalies, we cooled the patient to 24, 25 degrees in a water bath, and then when the heart stopped, we would open the chest, again the right chest, and pour ice-cold saline over the lung and the heart and gently massage the heart until the heart stopped, and then we could do the surgery. It was a Merendino Mori technique, and I assisted Professor Senning on several of these operations. It was not an easy surgery, but it was possible. And the pump oxygenator at that time needed about 2.5 liters of prime, a liter of blood and a liter and a half of saline, and it was impossible to perfuse smaller children with a blood volume of 300-400 ml of blood. And this is my only small contribution to cardiac surgery. I built this when I was in San Diego in America. I built the pump oxygenator for infants with a prime volume of about 300 ml. And this is how we started doing open heart surgery in infants and newborns in 1972 with a very good success. Nowadays, it is difficult to imagine that the risk of cardiac surgery in the best cardiac centers in the beginning of cardiac surgery in the 60s was extremely high. Aortic valve replacement at Cleveland Clinic, one of the leading institutions, was 23%. In the same time, John Kirkland published the results of the Mayo Clinic. In the 60s, it was a 20% mortality, and it was good numbers when they published the paper with the 20% mortality. Nowadays, impossible numbers. The only operation for coronary insufficiency was a so-called Weimer operation. We would prepare the internal memory artery here, leave the side branches bleeding, and then make a tunnel in myocardium and pull through this internal memory artery. Here it is how it is pulled through. It was a bloody operation and blood everywhere, and I was never convinced, but finally it was shown that this did help a little. But the real coronary surgery and the development of cardiac surgery started with the aortocoronary bypass as we know today. And when you look at the numbers in Zurich, number of heart surgery operations, the rapid increase in the 70s and the beginning of the 80s was really due to the coronary surgery becoming the most common procedure ever performed. When we switched to cardioplegia, I brought the cardioplegia from US in '79. Then we really reduced the mortality in coronary surgery to very low levels, and at that time we truly believed that we might approach zero mortality in cardiac surgery. Oops. Just a second. And then came my friend Andreas Grünzig with his idea of introducing a catheter, and the catheter into the coronary artery, into the stenosis, blow up the balloon and release the coronary stenosis. And it's interesting to watch these original slides from Andreas Grünzig, his first lecture. He gave it the first lecture in American Heart. His indications for coronary angioplasty were extremely strict. He was a very careful cardiologist. It must be a proximal stenosis, discrete, not a long one, non-calcified, and patients must have a disabling angina, really not treatable with a common means. That was a very conservative indication. And his first report is also interesting to learn from history, was a letter to the editor in 1978 in The Lancet. And this letter of the editor shows the results of his first 5 patients. But when you read carefully, you will see that the patients marked with asterisks, number 2 and number 4, where the dilatation was not done in Zurich, but was done in Professor Kaltenbach's department in Frankfurt. What happened is that after his first successful PCI in Zurich, Andreas Grünzig did not get any new patients for 2 months. He was very disappointed. He went to Frankfurt, where Professor Kaltenbach gave him possibility to it, and patient number 2 and number 4 were done in Frankfurt. And that shows how the old Roman proverb of nemo propheta in patria sua is still valid. First PCI operation, percutaneous dilatation done in Zurich, 77-78, and we published this in Annals of Thoracic Surgery, was not an easy procedure. In the first 95 patients, there were 9 serious complications. Necessitating emergency coronary artery bypass grafting, we were taking the patients to the operating room under continuous resuscitation and opening the chest under resuscitation, but we were very proud that we never lost a patient from the Grünzig complication, and none of them had a myocardial infarction because they were all revascularized within 2 hours after vessel closure. But in the beginning, the PTCA, or PCI it is called now, was a risky procedure. Where are we today? Look at the numbers in Switzerland, going from 92 to 2012, a rapid increase of the coronary dilatations and about constant number of PCIs. Nowadays, in Switzerland, only 20% of coronary artery disease patients will get a coronary bypass grafting. The same situation is in United Kingdom. These are results from United Kingdom. Seeing in violet are the number of the dilatations, and yellow the number of coronary operations. Coronary operations still going down. Interesting to note that New European Society, European Association of Cardiothoracic Surgery guidelines, which were published in 2010, gave a very broad role to the coronary bypass grafting. Coronary bypass grafting was considered better suggestion for patients than PCI in most of the anatomic situations. What has happened after these guidelines? Nothing has happened. Coronary dilatation still continued, they still continue to rise. So the guidelines, where everybody agreed upon, are just not being followed. And my friend Patrick Cerise, cardiologist from Bristol, always says it's not a question if invasive cardiology will replace the coronary surgeon, but only when. That is the opinion of many cardiologists. And it is disappointing. When you look at the patient, for instance, these are bilateral IMA, which I did about 20 years ago. And this situation, it is perfect. The vessels are perfect afterwards. Patient has no symptoms. And it is very interesting that after an implantation of internal memory artery, there is no progression of atherosclerosis distal to the anastomosis. And that's a very strange phenomenon. It's not quite known why. It seems to be that some people have seen the nitric oxide production in the internal memory artery protects against the distal atherosclerosis. Nowadays, the actual situation is like this. It is from Journal of American College of Cardiology, a patient with 67 stents inside. And this is what the Americans call a full metal jacket. It's absolutely impossible to operate on such a patient after 67 stents. This excessive stenting has been even discussed in the New York Times, a leading American publication that really can be trusted, about a doctor in Baltimore, who one day he implanted 30 stents by Abbott's in his various patients, and Abbott's representative was so happy about it, he spent more than $2,000 for a whole slow smoked pig. And this is a slow smoked pig developed to this cardiologist. Incidentally, this cardiologist landed in jail afterwards, and he has lost his license. But these are the excesses of percutaneous dilatation in the United States. Nowadays, you can read this all the time. When you look at the PCI, Westlake cardiologists get 20 years for unnecessary procedures. FBI reports that the Louisiana cardiologist begins a 10-year sentence. And there's another report for the cardiologist who falsified patient records goes also to 8 years in jail. This is a statement by one of the prominent American internist who is also very much interested in medical ethics. He says that the stenting belongs to one of the bleakest chapters in the history of Western medicine, that cardiologists are marching on because interventional cardiology industry has a cash flow comparable to gross domestic products of many countries and doesn't want to lose it. And this is true. When you look, for instance, the wealth of these biomedical companies, a couple of years ago, St. Jude Medical, a very attractive manufacturer of cardiovascular devices, was bought for $25 billion US. Billions, for you who are not familiar, it is 1,000 million. So $25,000 million they paid for St. Jude Company. When you look at the gross domestic product of Macedonia, which is 10.9 billion, they could have bought Macedonia 2 times over for the sum which they spent for it, but they didn't want to buy Macedonia at that time. This is the clinical situation which you can see nowadays. I have it from Professor Carroll in Bern. You have a patient with ascending aortic aneurysm and substantial aortic incompetence, and before operation he gets a coronary angio to see what is the problem. And he has a moderate stenosis in this LAD. What happens is, the needy surgery is obvious, he has to go. But patient first gets a stent in the LAD. And now what happens, that you have to do the Bental procedure, a complex operation, with a patient who is treated with 2 platelet inhibitors, and obvious problem with the bleeding, but the cardiologist doesn't see that. Nowadays we are living in the times of TAVI. And there are all kinds of balloon expandable, self-expandable stents. I worked on development of one of these valves myself in the early stage. Now you can see how the number of publications are increasing. This is for between 2008. There is a rapid linear increase in the number of publications in Medline about the problem of TAVI. Looking at the situation in Germany, which is very well developed, it is a rapid increase in TAVI, in replacement of the aortic valves. Nowadays, when you look for the report for German Parliament, the slide is in German, I'm sorry, but 56% of aortic valve replacements in 2014 were done by catheter technique. Interestingly enough, the number of aortic valve replacement surgically has roughly remained constant, meaning that they are recruiting the new group of patients which were previously considered to be inoperable. And growth of the TAVI, of transcutaneous aortic valve implantation, you can see the numbers projecting in 10 years that TAVI will grow 4 times the present volume. And nowadays, when you look at the projection of a global TAVI market, it is considered to be, in 2025, it will be $5 billion valid of the TAVI devices, and most of it will be in US and in European Union. In development are the valves about the percutaneous mitral repair. It is an established technique nowadays, and it's a basically surgical technique, Alfieri stitch. And now we can read about the experimental evaluation of transseptal mitral valve replacement by catheter alone. There are several devices already available for experimental evaluation. It is still not clinical routine. And there is also a work on the transcutaneous replacement or repair of the tricuspid valve. That is a development which you just go on, whatever you do. The same development takes place in the vascular surgery, especially in the major vessels. TEVAR is very attractive for the older patients, and the results are, I must confess, are very good. For instance, when you look at this very complex disease, a thoracoabdominal aneurysm, which Dr. Mitrev likes to do very much, and the results just done by catheter technique in TAVI are very good in the long term, and I see more and more patients being performed. And the patient prefer the surgery. It's obvious when you look at the thoracoabdominal incision to treat thoracoabdominal aneurysm. This is the biggest incision in surgery which I know of, opening the chest and opening the abdomen and releasing the diaphragm. It is beautiful for surgeon. Then you can have the access to the whole aorta, from aortic arch down to the aortic bifurcation. But it is a big operation. And when the patient sees something can be done like this with a catheter, with a puncture in the groin, and the same operation, same treatment of his aneurysm can be done, it's obvious the patients opt for this catheter treatment. The global endovascular repair, the numbers are relatively conservative, showing that about a third of the all aneurysm, aortic and thoracic, will be done by this catheter technology. Numbers in advanced countries are different. For instance, in endovascular treatment in Germany for the aneurysm of the abdominal aorta is more than 60% of the aneurysms are treated by endovascular treatment. And looking at the USA statistic, you can see that only less than 20% were done by surgeons, and 80% were done by endovascular technique of the aortic aneurysms. That's an interesting observation nowadays with the very close scrutiny which we receive as surgeons from the press and from the public. This is the first correction of which Professor Senning has described of transposition of the great arteries in 1958. And it was, we all did the surgery for many years. Adib Jatene published in 1982 his so-called arterial switch, just interchanging aorta and pulmonary artery, taking the coronary arteries out and implanting them in the pulmonary artery, and so treated it on the arterial level. The results, 1982, the paper which Jatene published, had a mortality of 51%. And when you look the lower, the long-term results of atrial repair, Senning technique, and this is from Paul Ebert in San Francisco, 52 patients, no mortality. Same results we had in Zurich in this time, no mortality. And then the new technique is published with a 51% mortality. And what's the lesson here? Now you can hear in developed countries, something like this, it will be impossible. Because nowadays, Andreas Grinzig would never be allowed to use his dilatation catheter because he made it at home in the kitchen, and we sterilized it in the operating room, and then it was used again. The Adib Jatene, who published this result with 51%, he would go to jail in Switzerland or in Germany for having a high mortality for the operation, which can be very well done with the other technique. So here, both procedures are now standard, but we have to accept the fact that public and governmental scrutiny might endanger the progress. It's very difficult to start now with a new operation, which inevitably will have some higher complication rate and some higher mortality. So what's going to happen in surgery? This is a famous Rembrandt painting of Belisar's feast, and showing the invisible hand writing on the wall. And we don't need a modern David to tell us what is going to happen in cardiac surgery. There will be areas of the cardiac surgery which are disappearing. That is obvious. Large proportion of coronary surgery will go to PCI. Atrial septal defect and PDA closure are mostly done, PDA practically exclusively by transcatheter technique, and most of the ASDs also by percutaneous technique. Coarctation aorta is treated with balloon and stents. Mitral and pulmonary stenosis I haven't seen in years now. It's all done by catheter dilatation. Arrhythmia surgery, which I like very much, is now done basically by catheter procedure, or if you cannot treat it, you put in a defibrillator. Pulmonary valve replacement is very well established technique with a catheter. Thoracic aortic aneurysm are going more and more to TIVAR. Aortic valve disease is TAVI, and transcutaneous treatment of mitral incompetence and tricuspid incompetence is very close. Now, when you ask me where to go in cardiac surgery, where the young cardiac surgeon should go, I think the first is that the minimal invasive techniques will have to be developed, because there is a huge difference between median sternotomy, which is very convenient for us. You can do everything, every operation can be done from median sternotomy. The patient don't like it. It hurts afterwards. It's a big incision. It has a long recovery. It has a complication rate by itself. Minimally invasive is very popular. We will have to go into hybrid treatment. Hybrid treatment of coronary artery bypass grafting, I'm not quite convinced, but it could be developed. Doing first from the mini thoracotomy, doing a coronary bypass internal memory artery, and then asking cardiologists 2 days later to put a stent in circumflex or in the right coronary artery, which is available. Arrhythmia hybrid treatment is very well possible. You do with thoracoscopically ablation of the pulmonary veins, left and right, and 2 or 3 days later you ask cardiologists to perform the mapping or ablate a couple of residual centers in the left atrium. Heart failure management will be also changing. Transplantation alone is not possible to increase because of lack of donors. Assist devices are on the horizon. And obviously we'll need in every institution to start truly cooperating heart teams, not by name only, but people who do work together. This is, for instance, one of the developments which we should watch about. These small cardiac assist devices, this one is put by catheter into the left atrium and pumps back into subclavian artery. And nowadays, these small devices, can be done by transcutaneous energy transfer. The first time that these patients can go swimming, they will have no wires coming out of the body because it will be transcutaneous energy transfer to drive the device. That is something we have to watch. It is an interesting problem. I had to fight several times in Zurich, being criticized for the costly treatment. And it is obvious that our treatment is costly. For instance, in Prautic and LVAD, although it's a very good operation, but elective LVAD as the bridge to transport costs about 140,000 euros, the operation alone. But the annual cost of keeping a murderer in jail in Zurich is about the same, 140,000 euros. And I've never seen anybody complaining about the cost of keeping a murderer in jail, but I have to defend the cost of a heart transplantation of an assist device. So it just shows that the illogical world we are living in. Heart transplantation will hardly be able to be increased because although the numbers in the last years have been slightly rising, but in developed countries the number of transplants is going down. These are the numbers in Germany. The lower curve, the green curve, is the number of new heart transplants, and it is going down. This is very worrisome because we have less donor hearts to deal with. Now, the one thing which might be, I don't want to put my foot in my mouth, but there is a possibility that the xenotransplantation, not the one we are thinking about, the monkey heart in the human, but xenotransplantation, well conducted, might achieve progress because the new developments in genetic engineering are modifying both the recipient and the donor, animal donor, to fit together. For instance, when you look, this is this CRISPR-Cas. This is the technique I Of course, I know nothing about it, but I read a lot about it because it's running now for the genetic engineering. You can basically change the genome change blocks in the chromosomes. And with this technique, for instance, when you look here about the heart, a genetically modified pig heart implanted in a boom worked for 2.5 years. So these are really progress, and one has to watch carefully the progress in the xenotransplantation. One change will happen in training for surgery. When the simulator training is obvious for pilot training, and when you sit there, you can program any complications, any kind of problem, and the people can train until they can treat every complication they happen during the flight. And when you look at two of these Swiss F-18 flying very dramatically near Matterhorn, the flying this F-18 cost $33,000 an hour in last year. And in simulator, you can train the pilot, train him even better, for $500 to $1,000 per hour. So obviously the way to go, and where the military goes, is for simulator training. So what are the approaching alterations in cardiac surgery, to start summarizing this long talk? I think that the numbers will go down of cardiac operations. I don't speak about Macedonia, which still has a huge backlog. I'm speaking about the Western Europe and United States. There will be less need for cardiac surgeons. Not so many will have to be trained as it was 20 years ago. And that the heart team will have to be established, real surgeon and cardiologists who work together on transcutaneous procedures where there is a great future. I think that the surgical training will be taken out of the operating room. The old system of see one, do one, teach one, this disappears. It is ethically unacceptable to have somebody trained on the next patient. So this will be taken out of the operating room, done in simulators, in wet lab or in dry lab. We have to accept the fact that our results will be strictly monitored and they will be published. This is the general trend nowadays, and we have to accept it, and this is true. The public has the right to know. There are a lot of problems with this. Nobody will want to do difficult cases or the dangerous cases. These patients might die, but we will have to live with the monitoring of the surgical results. And what we are already observing now in cardiac surgery, that it is splitting to subspecialties. When I look at my old programs, operating room programs at the beginning of 20th century, to do a transposition in the morning, and afterwards they prepared already a coronary bypass procedure, and then I would do a mitral valve repair and end up in the afternoon with a Torico abdominal aneurysm. This is gone. This is not. Nowadays there are congenital surgeons, adult surgeons. There are people who specialize in valves, who only repair mitral valve, but do it very well. Transplantation-assisted circulation is a profession in itself. Arrhythmia surgery and arrhythmia treatment also needs specialists as well as major vessels. And I also think that the smaller centers will disappear. Not the one, ZAN MITREV's one, it is big enough, but smaller centers will have difficulties in the future. So what it leaves now, to summarize, for the older surgeon here who will be able to influence the future, we should listen to the advice this famous French politician and diplomat, Talleyrand, who salvaged territorial integrity of France after Napoleonic War. He ran really the Vienna Congress. He made an immortal comment: the art of statesmanship is to foresee the inevitable and to expedite its occurrence. I thank you for your attention.